Hi there, my valued and highly treasured viewers and listeners, and welcome back to Progressive Pharmacotherapy Consultants. My name is Dr. Nath Aru, and I am the founder of Progressive Pharmacotherapy Consultants, which is a premier virtual clinical pharmacy institute for capacity building for the healthcare sector. The virtual clinical pharmacy institute with a difference, where patient safety, medication therapy management, and optimal clinical outcomes are very crucial and non-negotiable to us. Here, we seek to remain your premier source of crucial tips for high-impact pharmacotherapy services. So I kindly urge you to sit back and spare me part of your precious time to share a few tips with you. So welcome to part 15 of our Pharmacotherapy MCQ series. So welcome to question number 1. COA is a 34-year-old African American lady with recently diagnosed SLE who recently lost 6.8 kilos, which is around 15 pounds, from a former weight of 59 kilos. Now she complains of joint pain, fatigue, and there have been recorded low levels of proteinuria, the presence of antiphospholipid antibodies, and there is a worsening facial rash that is alarming to this dear lady. Now she was initiated on prednisone at a dose of 20 milligrams orally once daily, and hydroxychloroquine at a dose of 200 milligrams taken orally once a day. A few months into her treatment, she returns to the clinic, and although most of her SLE symptoms are well under control, she still has proteinuria. So my question to you is, which set of changes would be best for her medication regimen? Would you add ibuprofen at a dose of 600 milligrams taken orally thrice daily and quickly taper the prednisone dose? Or would you initiate mycophenolate mofetil at a dose of 500 milligrams taken orally once a day and slowly titrate it to twice daily as you taper down the prednisone? Or would you slowly taper prednisone and add calcium and vitamin D supplements? Or would you start golimumab at a dose of 50 milligrams administered subcutaneously once a month and change her prednisone dose to alternate day dosing? So I'll give you 10 seconds to make the correct choice. Opinion, B would be the correct answer. Immunosuppressive therapy, e.g. the use of mycophenolate mofetil, is indicated in patients with SLE with organ involvement. Now, giving such patients NSAID therapy and decreasing the prednisone dose wouldn't achieve disease remission, neither would it prevent further damage to her kidneys. Anti-TNF therapies have been associated with drug-induced lupus, so option D wouldn't be very ideal, and it would not be indicated in the treatment of SLE. So that leaves us with option B as our best bet. Let's move to the next question. Patient LKJ is a 60-year-old woman with a history of several episodes of acute gouty arthritis. She also suffers from heart failure and is a stage 2 chronic kidney disease patient. She presents with a painful, swollen great toe joint and the pain ensued around half a day ago. She isn't receiving any chronic gout therapy at the moment, and colchicine 1.2 milligrams is prescribed. That is meant to be followed by 0.6 milligrams an hour later. So my question to you is, which is the most appropriate approach to reducing this lady's risk of future gouty arthritis attacks after this one has resolved, after it's brought under control? Would it be initiation of 100 milligrams of allopurinol once daily alongside 0.6 milligrams of colchicine, also taken orally once a day? Or would you initiate 100 milligrams of allopurinol once a day in addition to 250 milligrams of naproxen taken every 12 hours orally? Or would you initiate naproxen 250 milligrams taken 12 hourly orally without uric acid lowering drug therapy, given that uric acid lowering drug therapy is contraindicated due to her CKD? Or finally, would you initiate colchicine at a dose of 0.6 milligrams orally once a day alongside 100 milligrams of allopurinol taken orally once a day 56 days after this gout attack has resolved? So I'll give you 10 seconds to make the correct choice. Personally, I would settle for option A. And I would like to remind you that use of colchicine daily for at least 6 months is recommended as acute gout prophylaxis when initiating uric acid lowering drug therapy, e.g. allopurinol, for example. Colchicine or naproxen is recommended for acute gout prophylaxis when initiating uric acid lowering drugs. Therefore, starting 100 milligrams of allopurinol orally once a day alongside 0.6 milligrams of allopurinol also taken once a day orally today would be our best bet. Although naproxen 250 milligrams twice daily can be used as acute gout prophylaxis, it shouldn't be used in this particular patient because of a history of CKD and heart failure, both of which can be exacerbated by NSAID therapy. Patients like LKJ with CKD have a risk of recurrent gouty attacks and should receive uric acid lowering drug therapy. The uric acid lowering therapy, for example allopurinol, and acute gouty prophylaxis regimens, e.g. colchicine, should be initiated as soon as possible after an acute attack like she suffered. And there is no need to torture her and wait for 56 whole days to do so. So let's move to the next question. Which of the agents listed below would you consider as being an ideal choice for a diabetic patient who totally refuses to manage her type 2 diabetes using injectable medication because of phobia for needles? Would it be dulaglutide or exenatide or linagliptin or insulin glargine? I'll give you 10 seconds to choose the correct option. In my opinion, C would be the correct answer. Of all the listed options, linagliptin is the only oral preparation. The other drugs, dulaglutide, exenatide, and insulin glargine, are administered subcutaneously by injection, which she fears, which she has phobia for, and therefore those would not be ideal therapeutic options for a patient who declines injectable preparations due to phobia for needles. Let's move to the next question. Which of the following agents would be the most appropriate for treatment of a patient who is experiencing hypoglycemic events with blood glucose reading 48, and we are told that this patient has just lost consciousness? Would it be 4 pieces of hard candy? Would you give this patient half a cup of freshly prepared orange juice? Or would you give 3 full glucose tablets? Or would you settle for glucagon administered intramuscularly? I'll give you 10 seconds to make the correct choice. Personally, because the patient is unconscious, I would settle for option D, based on the fact that the patient cannot swallow. The patient is unconscious. The first 3 answers or choices are incorrect, and D would be the best bet in this scenario. Let's move to the next question. In which of the following scenarios would you recommend the use of continuous glucose monitoring, which we abbreviate as CGM? Would it be in a 35-year-old patient with type 1 diabetes mellitus who is using an insulin pump, or would it be a 41-year-old patient with type 2 diabetes mellitus who also takes sitagliptin and metformin extended release in addition to basal insulin glargine? Or would it be a newly diagnosed 53-year-old patient with type 2 diabetes mellitus who doesn't want to use lancing device to prick herself? Or would it be a 77-year-old patient with type 2 diabetes mellitus who takes both metformin and glimepiride at recommended doses? I'll give you 10 seconds to choose the correct answer. I would settle for option A. Based on study evidence, a patient who is only on oral antidiabetic medications would not likely benefit clinically from the use of CGM. A patient with type 2 diabetes could benefit from this approach if often experiencing episodes of hypoglycemia, or if the patient lacks hypoglycemic awareness, which is unlikely to occur on a regimen such as sitagliptin plus extended release metformin in addition to insulin glargine. The most appropriate choice is a patient with type 1 diabetes mellitus who uses an insulin pump to provide glucose readings sufficiently often enough to appropriately assess safety and efficacy of the basal bolus insulin doses. So I would opt for option A. Let's move to the next question, which reads, what would be the most appropriate therapeutic agent to initiate in a patient with type 2 diabetes mellitus, a history of pancreatitis, and who is classified as end-stage renal disease? Would you give canagliflozin, or would you administer insulin detemir, or would you orally administer linagliptin, or would you subcutaneously inject exenatide? I'll give you 10 seconds to choose the correct answer. I would opt to administer insulin detemir subcutaneously. Now, canagliflozin is contraindicated in patients with an EGFR of 30 ml or less. So it's an inappropriate choice for such patients. Now, both dipeptidyl peptidase 4 inhibitors and GLP-1 agonists should be avoided in patients with documented history of pancreatitis, because both linagliptin and exenatide can cause pancreatitis and therefore are not advisable treatment options for such a patient. Therefore, that leaves us with insulin detamine as the best option in this patient with a history of ESRD and pancreatitis. Let's move to the next question. Mrs. QOP is a 29-year-old lady who was initiated on depomedroxyprogesterone for her menorrhagia. She has experienced heavy bleeding and requests for an agent to alleviate her suffering with this cycle. Now, she has a past medical history of anemia as a result of her heavy bleeding and DVT, which she suffered 3 years ago, according to her medical records, just after delivery of her last baby. What would you recommend for this lady? Would it be estradiol burst for 20 days? Would it be ibuprofen during her menses for 5 days, or would you administer tranexamic acid to stop the bleeding for 5 days, or would you give her citalopram for 10 days prior to her menstrual cycle? I'll give you 10 seconds to choose the correct option. I would settle for B. Heavy menstrual bleeding can occur when initiating this kind of depot injection. Now, although estradiol can be used for 10 to 20 days to treat heavy bleeding after initiating a progestin-only contraceptive, it isn't ideal in this particular case because estrogens are contraindicated in all females with a history of DVT. They would worsen the situation and endanger her life. Now, tranexamic acid is contraindicated in patients with a history of DVT as well, and citalopram can help with premenstrual symptoms including premenstrual dysphoric disorder, but it will not affect the bleeding, so it would not add value to this particular lady. And ibuprofen can improve pain related with heavy bleeding and reduce bleeding rates, so I would settle for B as my best bet. Let's move to the next question. Mrs. KAN is a 35-year-old lady with infertility who has had the following lab works checked. FSH is normal, LH is normal, estradiol is normal, but her prolactin is elevated. The TSH is normal. She informs you that she has menses every 45 days, unlike other normal women, and she has noticed some discharge from her breasts occasionally during the past 6 months. Currently she's on verapamil and ranitidine. So my question to you is, which of the following would you recommend as the best initial therapy for Lady KAN? Would it be metformin, letrozole, menotropin, or cabergoline? I'll give you 10 seconds to choose the correct answer. Would settle for cabergoline, answer D. Now, KAN has hyperprolactinemia due to the elevated prolactin levels and the symptoms of breast discharge. Both of those point me to hyperprolactinemia. Now, high prolactin levels are most likely causing her infertility, and cabergoline lowers prolactin levels, so it would be a good option for her. Now, letrozole would only be first line if she had other ovulatory related infertility issues such as POCS, amenorrhea, as well as infertility of unknown etiology, which does not apply in her case. And metformin is used to help with infertility related to POCS, so it would not serve this lady well. Now, menotropin is a gonadotropin therapy which is an alternative agent to induce ovulation for patients who have failed clomiphene or have documented low FSH or LH levels. In our particular case here, those levels are normal, so this lady would not require that remedy. Let's move to the next question. RMN is a 60-year-old female patient who complains of dyspareunia. Now, her past medical history is significant for hypertension and stroke, which she suffered 2 years ago. And her BP today in the clinic is 130 systolic, 74 diastolic, and her pulse rate is 88. What recommendation would you make for RMN during this appointment? Should she begin using conjugated estrogen plus medroxyprogesterone, or would you use that vaginal ring, fem ring, or would you opt for ospemifene, or would you recommend lubricating vaginal gel for this particular lady? I'll give you 10 seconds to make the correct choice. I would opt for the gel. Lubricating gel is the correct remedy for her because she has local symptoms, and non-hormonal products should be used for mild to moderate symptoms. The other three options are wrong because they are contraindicated in a case based on her history of stroke. They would endanger her life. Now, the first two are inappropriate because dyspareunia is a vaginal symptom, and these two products are for systemic symptoms like vasomotor symptoms with or without vaginal symptoms. Now, since she only has vaginal symptoms, vaginal therapy is preferred to systemic therapy to minimize any risks. So let's move to the next question. A 24-year-old lady who is 10 weeks pregnant presents to her gynecologist's office complaining of dyspnea, wheezing, and chest tightness during the day, and this has been going on for the past few weeks, and she also wakes up with these symptoms once to twice weekly, and that has been happening for the past 1 month. She has been using her salbutamol inhaler daily, and her peak flow readings are consistently in the yellow zone. She has a past medical history of asthma and eczema, and her medications include salbutamol puffs. The doctor prescribed 2 puffs PRN every 4 hours for symptoms, but she is afraid to use it because of her pregnancy. Now, what would be your best recommendation to her to manage her symptoms? Would you advise her to use beclomethasone 80 micrograms, 2 puffs twice daily, or would you recommend 10 milligrams of Montelukast taken orally once a day, or would you recommend the combination product fluticasone with salmeterol 250/50, a puff in the morning and 1 in the evening, or would you put down 60 milligrams of prednisone once daily for 6 days? I'll give you 10 seconds to choose the correct answer. Settle for A. Asthma management in pregnancy is the same as in non-pregnant patients. This patient would be staged as moderate persistent based on her symptoms, and using the guidelines. Moderate persistent asthma is treated with moderate dose inhaled corticosteroids as monotherapy, or a low-dose inhaled corticosteroid co-formulated with a long-acting beta agonist, a LABA. Beclomethasone is a moderate-dose inhaled corticosteroid, in my opinion. Therefore, it would be ideal. Montelukast, which is a leukotriene inhibitor, is considered an alternative therapy for mild persistent asthma. And inhaled products have low bioavailability and minimal exposure would occur to the fetus, whereas oral corticosteroids would expose the fetus to high steroid levels. So I would not opt for D, I would not opt for C or B. I would settle for alternative A. Let's move to the next question. Just before I talk about this one, fluticasone and salmeterol is a moderate dose inhaled corticosteroid co-formulated with a long-acting beta agonist, a therapy that is preferred for severe persistent asthma. So hers is not yet very severe. I talked about the fact that oral corticosteroids burst therapy for such a patient would only be recommended for acute exacerbations, and I would be reluctant to do so in pregnancy. Now this patient is not having an acute exacerbation, and her peak flow readings are in the yellow zone rather than the red zone, so that makes it that rules out acute attacks. So in our next question, SMO is a 15-year-old adolescent boy. He's diagnosed with the mild persistent asthma. His FEV is 92% of predicted. He has no nighttime awakenings, and he uses his salbutamol 3 to 4 times weekly when there's chest tightness. So which of the treatments listed below would be recommended for him consistently with preferred step 2 therapy according to the NAEPP guidelines? Would it be low dose inhaled corticosteroid therapy? Would it be low dose inhaled corticosteroid therapy plus a LABA? Or would it be a LABA? Or would you opt and settle for Montelukast oral therapy? I'll give you 10 seconds to make the correct choice. Personally, I would recommend low dose inhaled corticosteroid therapy. According to those guidelines, the NAEPP, low dose ICS therapy would be consistent with step 2, and Montelukast or agents such as chromonil would both be considered alternative therapy, not first line for step 2, and they are not preferred therapy. Combination of LABA and an ICS would be step 3. He is not in step 3, and LABA as monotherapy is contraindicated in asthma treatment. So that makes B, C, and D wrong. I would settle for A as my best bet. Let's move to the next question, where TTO is a 16-year-old adolescent, and he informs his teacher that his breathing is worsening with a cough, wheezing, and dyspnea. He's taken to the school nurse, and the school nurse offers a peak flow meter, and the boy blows 60% of his personal best. In which zone of his asthma action plan would you place him based on symptoms and the peak flow readings? And what would be the best recommendation for TTO at this time? So would it be green zone, and would you recommend he uses salbutamol 15 minutes prior to exercise only? Or would it be yellow zone, and would you recommend he uses 2 to 4 puffs of salbutamol and repeats in 20 minutes time when necessary? Or would you classify him in the yellow zone and recommend he nebulizes salbutamol once and then takes an oral corticosteroid burst? Or would you classify him red zone and call emergency services. I'll give you 10 seconds to choose the correct answer. This boy is in the yellow zone, and he'll do just fine with 2 to 4 puffs of salbutamol inhaler, which can be repeated PRN after 20 minutes. Now, based on the peak flow reading, which was 60% of his personal best, and his symptoms, TTO falls in the yellow zone of his asthma action plan. Now, for his yellow zone, although you can administer either 2 to 4 puffs or nebulizer dose, you can't administer any oral corticosteroid bursts at this time. Yeah, so that rules out C, A, and D. So I would opt to allow him to inhale 2 to 4 puffs PRN. Let's move to the next question. JPK is a 64-year-old woman who has been actively smoking for the past 40 years, and she smokes approximately 1 pack a year. Spirometry reveals an FEV of 75 of the predicted, with an FEV to FCV ratio of 64%, and this man reports no exacerbations in the past year, and the CAT symptom score is above 10. He was given a long-acting muscarinic antagonist daily and cancelled on smoking cessation. However, upon his follow-up visit to the clinic half a year later, he reports having persistent dyspnea. He has reduced his smoking to half a pack daily, and alongside that he uses the 4 mg nicotine gum every 2 to 4 hours when the urge grows very strong. So what recommendations would you make for managing his COPD at this time? Would you add ICS and a LABA to his regimen? Would you switch him to an ICS and a LABA? Would you add a LABA alone, or would you switch to modafinil? I'll give you 10 seconds to choose the correct option from those listed above. Adding a long-acting beta agonist. Now, JPK falls into the patient group B and is using a long-acting beta agonist. Now that he continues to have persistent dyspnea, it is recommended that a long-acting beta agonist is added. He's using a long-acting muscarinic agent, so you need to add a LABA. Now, an inhaled corticosteroid and a long-acting beta agonist combination with or without a LAMA could be recommended for patients if blood eosinophil counts are equal to or above 300 cells per mm, or less than or equal to 100 cells, and equal to or more than 2 moderate exacerbations or hospitalizations have been reported by the same patients. However, that information is not provided to us in this question, so I wouldn't go that way. And then modafinil isn't indicated in the treatment and management of COPD, so adding a LABA to his muscarinic agent would be our best bet at this stage. Let's move to the next question. AFG is a 59-year-old man and he reports to the clinic. He has a past medical history of depression, hypertension, type 2 diabetes mellitus, and gout. He has a BMI of 37. He's really obese, needs to check his weight. Over the past few years, Mr. AFG has noticed less energy and a daytime sleepiness. And his concerned wife reports to you that she's worried about his loud snoring and abrupt breathing interruptions during the night, where he sounds like he is gasping for breath. Now, you are told AFG is diagnosed with obstructive sleep apnea after a sleep study. Modafinil is scheduled to be added to his medication list. So, which of the following statements is most accurate about it? Is it that patients should avoid using continuous positive airway pressure when put on modafinil? Or is it true that patients should use continuous positive airway pressure with modafinil? Or is it true that modafinil is considered first-line treatment in such patients? Or is modafinil superior to weight loss as an intervention in patients with sleep apnea? So I'll give you 10 seconds to choose the correct answer. For B, we know that treatment options in obstructive sleep apnea are very limited. We have very few modalities. When using modafinil for this particular condition, it's recommended to rule out other causes for sleepiness while being on positive airway pressure therapy. And modafinil should always be used with continuous positive airway pressure and isn't considered first-line treatment. And weight loss is a strong recommendation despite limited evidence out there. So I would settle for B as the correct answer. Let's move to the next question. HPB. A 47-year-old woman has been smoking 1 pack daily for the past quarter century. She smokes her first cigarette within 30 minutes of waking up, and she has quit during both her pregnancies and was able to abstain without any medications during pregnancy. Now you are told that HPB has tried to quit smoking using nicotine patches 21 milligrams daily for about 3 years ago, and reports that the patches helped her cravings for smoking reduce, but she was unable to fully quit. She has a past medical history of anxiety, hypertension, insomnia, and because she took NSAIDs for too long to relieve her pain, ulcers ensued. She is currently on citalopram, depo-provera, hydrochlorothiazide, and she takes melatonin to ease her sleep. Which of the following treatment options for smoking cessation would be the best recommendation from you for HPB? Would you start bupropion 150 milligrams twice a day? Would you initiate nicotine patch 21 milligrams on the skin once a day? Or would you combine 21 milligram nicotine patch and advise her to chew the 2 milligram gum every 2 to 4 hours when the craving overwhelms her? Or would you start the 2 milligram lozenges every 4 hours when the craving is high? I'll give you 10 seconds to choose the correct answer. I would opt for C as my best bet. Now, nicotine patch treatment has failed this lady in the past, and the lozenges wouldn't be indicated at a dose of 2 milligrams since she smokes within 30 minutes of waking, and it's recommended to be used scheduled during the first week when used PRN in the above case. Now, bupropion, despite being a viable option, may cause concerns with anxiety and insomnia, which are an issue in this particular lady's case. And we know that combination therapy of the gum alongside the patch have been proved effective in many cases. So I would opt for answer C. Let's move to the next question. HDM is a 67-year-old man who has been diagnosed with COPD exacerbation. For his breathing, he inhales fluticasone co-formulated with salmeterol in the morning and in the evening. He also uses tiotropium once daily and inhales salbutamol PRN every 4 to 6 hours. And he describes increased sputum volume, purulence, and increased dyspnea. His most recent COPD assessment test, the so-called CAT test score, was 9. So my question to you is, why, in your opinion, would an antibiotic be indicated in this particular case? Is it because the patient is inhaled corticosteroids and a LABA combination? Or is it because the patient is experiencing increased sputum? Or is it because the patient is experiencing increased sputum volume and purulence and increased dyspnea? Or is it because he had a CAT score of 9? I'll give you 10 seconds to choose the correct answer. Settle for option C. Now, patients with a COPD exacerbation should receive an antibiotic when they have what we call the 3 cardinal symptoms of increased sputum volume, increased purulence, or increased dyspnea. Other indications for antibiotic use in such patients may be if they have 2 of the cardinal symptoms and one of them is sputum purulence, or if the patient requires mechanical ventilation. So I would opt for C and not the other options. Let's move to the next question. GOT is a 43-year-old obese man with uncontrolled type 2 diabetes, mellitus, and hypertension, and he has been smoking 1 pack a day for the past quarter a century plus. He is currently on amlodipine, aspirin low dose, atorvastatin, insulin glargine for his basal insulin, and he manages diabetes with metformin and sitagliptin on top of the glargine. So he has quit smoking before and recalls gaining about 8 kilos. His physician is concerned about causing additional weight gain with smoking cessation. So how best would you educate Mr. GOT in relation to this particular concern? Would you tell him that nicotine gum will prevent weight gain? Or would you tell him that bupropion can delay weight gain? Or would you tell him that nicotine patch can cause weight gain? Or would you tell him that weight gain is not normal with smoking cessation? I'll give you 10 seconds to make the correct choice. So I would opt for B. Bupropion can delay weight gain. Now, patients always have some weight gain with smoking cessation. Nicotine patches don't cause weight gain at all. And bupropion SR and 4 mg nicotine lozenges and gum can all delay weight gain, but not necessarily prevent it. So my esteemed viewers and listeners, if this video helped you in any way I would like to request you and remind you to like it and give it a thumbs up. I would also urge you to subscribe to my YouTube channel if you haven't yet done so. I would like to tell you that I sincerely appreciate your current partnership and your continuous collaboration with me, and I would like to promise you that the best is yet to come. I thank you very much for viewing, and I hope to interact with you in part 16 of this series. Thank you very much for your support.